Good afternoon, ladies and gentlemen. My name is Jean-Luc Fellailly. I am head of the Department of Cardiothoracic Anesthesia and Intensive Care in Lyon, in France. And I am both honored and pleased to chair this ProCon debate devoted to the validity and clinical interest and usefulness of the HPI technology, a machine learning algorithm based on the features of the arterial pressure waveform and commercialized by Edwards Life Sciences. The proposition will be defended by Dan Longrois from Paris. Hello, Dan. And the con-position by Johannes Enevoldsen from Aarhus in Denmark. Hello, Johannes, and thank you to be here. To briefly introduce the debate, I would remind you that hypotension is a daily problem in the OR, and if a strong association between hypotension and adverse outcome is reproducibly reported in the literature, the causality is not clearly demonstrated. Further, we actually do not know if the correction of hypotension with or without a treatment protocol improves outcomes, as published RCTs report conflicting. Thus, avoidance, and the words are important, avoidance of hypotension rather than correction of hypotension is recommended to date in the 2022 ESAIC guideline. Almost 20 studies have been publishing since 2018, globally validating HPI derived from both invasive and also non-invasive arterial pressure waveform analysis. 5 of them are RCTs, comparing an interventional group monitored with HPI to a control group as a standard of care. These 5 studies have been gathered in a recent meta-analysis showing a significant decrease in intraoperative hypotension in the HPI group. However, several questions remain. First, does HPI work better than a simpler and costless model using, for instance, only the absolute value of mean arterial pressure? Second, are we sure that prediction of hypotension with HPI does not lead to overtreatment and intraoperative hypotension? And third, the definitive interest of HPI associated with guidance treatment protocols to improve outcome and not only to reduce hypotension has to be confirmed in well-designed, large-scale, randomized studies. No, let's now listen Professor Dan Longrois to defend the proposition.
Thank you, Jean-Luc. It's a pleasure to be here, and it's an honor to be able to bring some arguments after a ProCon that we had the pleasure to share within a recent EJA article. So my point of view is that HPI may be clinically relevant. So you understand it's a conditional. I don't have the proofs as Jean-Luc just mentioned. And just before I go further, I have an academic credo, which is that physiology is absolutely mandatory for correct interpretation of what the monitors, the hemodynamic monitors in this case, tell us. And therefore, both the monitoring technique and the physiology behind it are probably both important to be able to take robust decisions in terms of management of arterial hypertension in this case. And second important message that I would like to share with you is that I, for many years, been proctoring for Edwards Life Science. That is, I teach the way this monitor and HPI technology could be used. So I work with them. I do not work for them, of course. So I brought up 3 types of arguments why I think that HPI is a credible technology. The first one, and I think it's a very strong argument, is that there's a fairly robust physiological background on the way HPI was derived, and I will not actually reinforce what Jean-Luc Fellahi said, is because we don't have the proofs that correction of arterial hypertension actually improves outcome. In both the 2014 and the 2022 ESAIC guidelines, we reinforced the issue that arterial hypertension should be prevented rather than corrected. So I would like to share with you what I consider to be the very strong physiological background behind the HPI. The second, which then of course will come as an important element of discussion with Dr. Enevoldsen, is that there's noisy measurement arterial blood pressure. And I will share with just 2 slides of what this noise means and what the consequences of this noise can be in terms of definition of arterial hypertension. So because of the noise, what I put forward is that I do not think it is credible to define arterial hypertension as mean arterial pressure lower than 65 millimeters of mercury. And when the mean arterial pressure is 66 millimeters of mercury, that would define normal tension. It is simply not consistent with this knowledge on the noise of measuring arterial pressure, which is a very vast element of our knowledge. And finally, of course, Dr. Enevoldsen will show you what the limitations of the way HPI was calculated could bring. And I can only agree that we should be very cautious about this. But what I would like to reinforce is the fact that when you build an area under the curve, you actually look at sensitivity and specificity. And when you maximize them, this is the principle of area under the curve, by maximizing both sensitivity and specificity, this means that the clinical consequences of a false positive or a false negative diagnosis in this case would be similar, which is not the case. So only clinicians can allow a clinical significance to a false positive or a false negative diagnosis. So in this context, we clearly stated in our pro article is that I'm not bothered if the sensitivity of HPI is too high, if this increased sensitivity with possible false positive actually results into not overcorrection, but clinical reasoning concerning the mechanism of the arterial hypertension. And this seems very, very important to us, and I think also to clinicians. So let's just me go to the physiological background very quickly. So the common reasoning now is that you define hypotension map lower than 65 and normal tension. And so you have a dichotomous approach on hypotension and normal tension. And what HPI technology brings to the forefront is that there are actually possibilities to detect early instability of the hemodynamic and cardiovascular system before the occurrence of arterial hypotension. And therefore, I don't like the term prediction because it's only detection of early instability. And this is based on something that we know ever since we were on the bench of medical school, is the baroreflexes. So the baroreflex, which has retained most of the attention, is the high pressure baroreflex, which are in the arteries, the coronary arteries, the carotid artery, but there are also low pressure baroreflexes, and those are probably the most important because they are activated when there's a decrease in preload, let's say, or change in preload before the occurrence of arterial hypertension. And this seems to me a very, very robust, in this vast literature starting in the late 50s and going up to today, showing that the activation of the low pressure bioreflexes are essential, and it is very important. And as you can see, this can activate not only and modulate the sympathetic parasympathetic balance for the heart rate, but also vasoreactivity. And this explains why you can actually, and this is what those who imagined HPI and published it in 2018, looking at the shape of the arterial pressure curve in the radial artery, this is very consistent with activation of low pressure bioreflexes before the actual occurrence of arterial hypotension. I would not go into detail, but it is my interpretation that is very, very strong physiological background behind HPI. Now, just the second type of argument is the noisy measuring arterial blood pressure. This is just one of the articles that compared the oscillometry with a radial artery in ICU patients, in critically ill patients. And just to make a very long story very short, the noise, as you can see here, is absolutely huge. So we're talking in MAP variations between -15 to up to 40 millimeters of mercury. And that is, in an individual patient, this is absolutely very important to take into consideration. And therefore, one should not be able to dichotomize arterial pressure into hypotension and normotension around a single value. And I think this is the main limitation. And this is probably explains why the authors of HPI in 2018 chose to have a gray zone and define hypotension and non-hypotension in the way they define it. And Dr. Enevoldsen will actually detail on this. And there's also, just to remind you, there's very convincing data that there may be gradients between the central arterial pressure, this is the femoral arterial pressure in this case, and the radial artery. So once again, this is another source of noise, and one should take this noise into consideration. And finally, I come to this issue of the clinical consequence and clinical value of a false positive or a false negative diagnosis. So what Dr. Enevoldsen is going to show you that in the left part of the slides, you have the area under the curve that was actually developed by the HPI authors in 2018. And he rightly criticized that this sensitivity may not look as one would expect. And I told you, if the HPI is oversensitive, well, of course, you can argue that this could bring over-treatment of arterial hypotension. I would like to believe, but I may be wrong, that this is going simply to trigger clinical reasoning on what the mechanism of arterial hypotension are. This will be debated further. So my personal point of view, to summarize, is HPI is a tool to detect, I don't like the term predict, and I insist on this, so as a tool to detect early cardiovascular instability, I think HPI is clinically interesting. There are many uncertainties related to this and other hemodynamic monitors. And the real challenge is to document the way in which HPI may influence outcome, including inadequate clinical reasoning, which will be translated into over-treatment of arterial hypertension. So I'm now ready, of course, to listen to Dr. Enevoldsen and furthermore debate. Thank you very much.
Thank you, Dr. Felahi, for the introduction, and thank you, Dr. Longrois, for the presentation. I'll not address the arguments directly for now, but I, of course, agree that it would be very nice if it was possible to predict hypertension. I don't disagree there, but I do not believe that HPI works, and I believe that using it could cause overtreatment. And the reason for this is a severe error that was made in the development of the HPI model. And this error has both hindered the model from learning, but it has also caused the reported performance of the model to be highly overestimated. So I will spend the next few minutes trying to explain this error, because I truly believe that if more people understood it, we would not still be having this discussion about HPI. So together with my former PhD supervisor, Simon Vistisen, I started looking into how HPI was developed, because the results presented for the algorithm were simply too good to be true. So the original article presenting HPI shows this ROC curve for HPI's ability to predict hypotension 5 minutes into the future.
And it has this strange shoulder with a very high specificity. And we can see that there is a HPI threshold where the specificity is 100%. And this implies that when HPI is above this threshold, hypotension will occur with 100% certainty. And this seems quite unrealistic. So we started looking in to how HPI was developed by reading through the original article presenting the model to see if something in the data selection could explain this extreme performance. And HPI was developed using a lot of arterial waveforms. So distinct hypotensive and non-hypotensive events were identified, and the HPI model was trained to differentiate between these. Hypotensive events were defined as MAP below 65 for at least 1 minute, and then the arterial waveform 5 minutes before each event was used to generate numerous features that could potentially be used to predict hypotension. On the other hand, non-hypotensive events were defined as 30-minute sections with a MAP that was always above 75, and then the midpoint of this section was used to generate features indicative of non-hypotension. So this means that data for predicting non-hypotension will, by definition, always have a MAP above 75, and this creates the 100% specificity, because with this data selection, if we see a MAP below 75, it can only correspond to future hypotension. And this design was used in both training and validation of HPI. And here is an illustration of what this selection does to a ROC analysis. So on the y-axis here, we have the outcome that we want to predict, a value that is dichotomized into hypotension or non-hypotension around a threshold of 65. And then on the x-axis, we have the MAP 5 minutes earlier. And we can see that on this data, MAP alone is a quite poor predictor of hypotension. Then, if we remove the most difficult situations where the outcome MAP is between 65 and 75, sometimes referred to as the gray zone, then the prediction becomes quite a lot better. And I believe that this is what the developers of HPI intended to do. What they actually did was create this biased selection shown in the right panel, where non-hypotensive events always have a MAP above 75 in the prediction data, whereas hypotensive events can have any MAP value in the prediction data. And we can see that this selection results in a MAP curve with the same extreme specificity as presented in the original HPI article. And this problem would have been immediately clear if the performance of HPI was compared to that of MAP itself. However, the only direct comparison between MAP and HPI was published last year, and it showed exactly identical performance between HPI and MAP for predicting hypertension. So I found no reason to believe that HPI is any better than MAP for predicting hypotension. And also, the advertised positive predictive value of more than 90% for HPI is highly overestimated. And Simon and I are actually analyzing some preliminary data and can see that it's closer to 10 to 20%. So that is my conversation against HPI. Thank you.
Thank you, Johannes, for your presentation. Thank you, Dan. We can now take a couple of minutes to discuss. Dan, do you have any question or any comment for Johannes in response?
So the issue is that when you look at the development of HPI, Johannes said it's an error. My interpretation is that it is a choice, because when you look at the way in the methods and the supplementary material, they clearly made the choice to define normal tension at a level higher than MAP 75. They should have explained why they made the choice. So this choice, as shown by Johannes, actually is responsible, at least in part, for the very, very high performance. And this curve, which looks a little bit weird, the area under the curve, with sensitivity, which is very, very high initially, and then this unusual breakpoint. Now, I wouldn't call this an error. I just call this a choice, but you can criticize the authors for not actually explaining why they made this. My second point is that when you remodeled and you recalculated in several articles, the area under the curve for the map, in most of the cases, the map was an empirical map. It was not an area under the curve in the systolic part of the curve. It was diastolics plus 1/3 of the differential pressure. And therefore, I think that the real modified area under the curve for the HPI, if they take into consideration your suggestion, and probably they should, is to do the whole actually retraining and deep learning by not choosing a gray zone. This would be, for me, convincing. So my point would be, I fully agree with the criticism that comes from the choice made by the authors. They may actually overestimate the performances, but I am not convinced that the calculations, even in the last article that you mentioned, when looking at the area under the curve for the MAP versus HPI, is really, from a methodological point of view, really consistent. So I agree with your suggestion, not fully agree with your interpretation.
Thank you, Dan. Johannes, maybe a short response?
Yeah, so I understand the want to clearly differentiate between hypotension and non-hypotension by excluding the gray zone to better train the model. The problem is that they also excluded the values below 75 for the prediction data, making the prediction completely free. Like when you observe a map in the prediction data below 75, you don't need to do any training. It is always going to correspond to non-hypotension. So the HPI model will not learn anything from all the other probably useful features, because it only has to look at map and say, if it's below 75, then it's hypotension. So it doesn't learn due to this biased selection. And I don't understand why they choose not to show HPI compared to MAP for predicting hypotension in all these validation studies. They compare it to delta MAP, like the change in MAP, which is useless for predicting hypotension, but they should just have compared it to MAP directly. And I don't understand why they didn't do it originally, and I don't understand now that after our criticism, they haven't reanalyzed that data and published those results.
Okay, thank you for your response. To conclude, I would ask you just one question, and we can start with Dan. Knowing what we know, what do you recommend at the very moment for the care providers regarding HPI, and how do you see the next future?
So I would say use it critically, be aware of potential limitations, and do not go directly to treatment, because if it was the way it's supposed to do, it would trigger your attention a few minutes before actually hypotension occurs. So given the way they manage their secondary screen, it will allow the user to see eventually what the mechanism of arterial hypertension could be. And this is my only and single message. Do not immediately treat because you have a few minutes, but do have a clinical reasoning on the mechanism.
Thank you very much, Dan. Johannes, the same question for you?
Yeah, I'd say I see no reason for using it. And if you actually want these few minutes, if you want to treat a bit earlier, then set a MAP alarm for 75 or 72, and then you use that to consider whether you have to intervene or not.
Okay, thank you both, and we will see how it goes in the next weeks and next months. Thank you. Bye-bye.